with the risks, we'll talk about the most rare and the most severe first. So there's approximately a 1 in 2,000 to 1 in 4,000 chance of a serious infection that can cause vision loss. Now, that risk applies even if you were to just put a needle into the eye and remove it, that risk is applicable. It's basically breaching the eye's wall. That risk is the same. The risk has been reduced significantly in recent years with studies that have come out of Europe that showed if you inject an antibiotic at the end of the surgery, you reduce the risks dramatically. Also, depending on the facility where the operation is done, so like myself, Dr. Erica, Dr. Mitchell, we only operate at facilities that have an excellent track record in terms of their sterilization practices, etc. So with those two things combined, along with a slick technique and short operation time, we've been really able to, well, the medical community has been able to really push those risks down significantly to a significantly rare and low level. We also do give patients information on what to look out for. So if an infection, touch wood, were to happen, 1 in 4,000 chance, then it may, the time will become most apparent is at the 1 week to 10-day mark. And so we always give patients the warning signs. And if you get to the hospital in time and get an injection of an antibiotic in the eye, there's actually a 50% chance of resolving it. But unfortunately, the other 50% chance is losing vision. So actually, the risk of vision loss is even lower than 1 in 4,000. If the patient is always on the lookout and follows all the instructions that we give, and we give our phone numbers as well, so that if the patient has any worrying symptoms, they can call us and we can instruct them what to do. We can even ring up the public hospital and say, hey, my patient's coming, get some antibiotics ready, please inject them ASAP. And like I said, if with early presentation, we can turn around 50% of cases. So that's, I would say, is the most rare and severe risk, but we manage that at multiple levels to make it extremely, extremely rare. The second, group of risks are a technical complication. So technical complication may include a tear in that capsule that we talked about that holds the lens. It may include part of the milky lens going to the back of the eye, or it may include capsule instability where the little strings that suspend it inside the eye, the integrity may not be perfect and may be off center. So we may need to do follow-up procedures. The published risk of those secondary technical complications happening is about 1%, so 1 in 100. But nowadays, again, the instruments are better, the techniques are better, so it's actually a little lower than that. It's probably more like 1 in 200. What I always say to patients is, if one of those things happens, if we manage it well, there's still a very good chance you're going to have very, very good vision. We may not be able to put in the agreed upon lens, however, depending on the robustness of the capsule that's left, because you really need a lovely, strong, stable capsule with a intact posterior surface or back surface to put in the premium lenses. So most of the time, we may need to do a follow-up operation. So a retinal surgeon may need to go into the back and remove any cataract pieces that drifted towards the back of the eye, and we may need to put in a different lens than the one agreed upon in a different position than the one agreed upon at a later date. But I always say to patients, like I said, you still generally get good vision, maybe not the perfect vision we were aiming for, but you still get good vision. It just takes a bit more work and a bit more time because the techniques are so sophisticated. There are only some other very rare things that can happen that actually can leave a lasting effect on the vision. One of them is retinal detachment, but that's extremely rare. Generally, if patients have already had the gel in the back of the eye or the vitreous come off, then that risk is virtually zero. The other risk is having swelling in the back of the eye or macular edema, which is swelling of the sweet spot. And in many patients, drops for 6 weeks can make that go away. And we also do pre-treatment with certain types of drops that have been shown to lower the risk of that by the European studies. And sometimes patients need injections to treat it as well. And only a very, very small number of patients may need ongoing treatments, either ongoing drops or injections to settle it down. But that's the nature of the beast, so to speak. It's an extremely good surgery, extremely successful surgery, but when you're dealing with a human body, you can never say 100% because we just don't know how bodies will react.
And I guess there's a whole post-surgery care routine that you educate patients about, like using drops, and I think at nighttime you encourage them to use like a patch or something as well so that they don't rub it. There's a I think for a week or two they have to follow a certain routine, don't they?
Yeah, absolutely. So all our patients get an information pack about what happens, before, during, and after the surgery, along with their drop regimen if the doctor has decided to use it, and along with do's and don'ts in the first few weeks, few days, etc. Because the wounds are now smaller and the surgeries are better, we're really pulling back on all the restrictions. So, for example, we recommend patients wear a shield overnight over the operated eye, but only for 3 or 4 days. And the reason is people can often, like turn their head and squish their eye into the pillow, etc., unknowingly during their sleep. But the wounds are so small nowadays that you don't need to do that for weeks on end. Like 3 to 4 days, at most 7 days, depending on the eye and the person and how exposed it is in comparison to their brow ridge, etc., will do the job. We also ask patients to avoid strenuous exercise or heavy lifting for 2 to 4 weeks, and avoid swimming for 4 weeks, just because they'll be on steroid drops during that time, and we don't want to introduce any sliver of risk of infection by going into a pool or something like that. But really, by 4 weeks, everything's done and dusted, and it's a long forgotten memory.
From what I've seen, at least in the public system in Queensland, is that patients tend to get like one eye done at a time. But I'm wondering, like in like a more private setting, do the majority of your patients get both eyes done just to reduce downtime?
It depends. So it depends on the patient, it depends on their eye, and it depends on the lens selection, and it depends what their job is. So, for example, somebody who's retired, but their family sort of can't bring them in several times, etc., and they'd rather just recover at home over the first week or so, and then sort of get up and get going, and they don't have any ocular diseases. So the cataract's going to be just a straightforward cataract. And also, if they are going for a lens where, like, most people tolerate, so either a monofocal or extended depth of focus lens, then doing both eyes on the same day would be an option, a favorable option. And there's lots of research that shows there's no additional risk to the eye in a normal eye. And if we're putting in a pre-agreed upon lens selection that is mostly tolerated by people, then it can be quite effective. However, there are some people who are still working, and at the end of the day, it's a surgery, and you'll still be sensitive to light, and you'll still be a little bit uncomfortable, a little bit itchy, a little bit watery. So for those people who need to work from home because they've got a busy job or what have you, we recommend that we just do one eye to let their other eye just do the work, and then a week later we do the second eye. And just that week offset gives them a little bit of time for the operated eye to relax, be a little less itchy, a little less red and watery, a little less glary, and make them more comfortable. And the other group that I personally don't do bilateral surgery on is patients having multifocal lenses, because we want to put one in one eye, see if they like it, see how the brain adapts to it within that week. And if everything's all good to go, then we're good to do the other eye. Whereas if they come back and they say, look, the nighttime symptoms are really problematic for me, then we may defer the other one a little bit and just see how it settles over the month. And if it does settle, then we proceed with the same plan. And if it doesn't settle, then we can put non-multifocal in the other eye to offset the pros and cons of each lens and give them a good overall, a more tolerable overall blended vision.
Well, we've talked about cataracts, but I know that the other eye care field, that's probably the wrong word, but I know the other eye care thing that's well within your wheelhouse is glaucoma. So is there any sort of connection between cataract surgery and susceptibility for glaucoma?
I wouldn't say there's connection in that order, but there is a connection in that both of them affect patients who are in their sixth decade or greater. So they're more common in people in their 60s, 70s, and 80s. And just by virtue of that epidemiology, it's common for people to have both conditions, but one doesn't necessarily lead to the other. So it's very, very rare for cataract surgery to cause glaucoma, unless the patients had lots of problems and required multiple surgeries afterwards, then maybe. But it's very, very rare for one to cause the other. But generally, patients come to us with concurrent disease, and therefore it's an opportunity to treat both of the conditions at the same time. And from our last interview, you remember I said cataract surgery is an unmissable opportunity to put in a minimally invasive device and give us a 25-30% reduction in pressure, reduction of the load of drops, anti-glaucoma drops on the eye, to help the patient along. And in some cases where there's a variant of glaucoma called narrow angle or angle closure glaucoma. And this is where the lens has become so thick that it's pushed everything forward and then pushed the drainage system of the eye extremely narrow because of that backward pressure. And so once we remove the lens and we put in the lens implant, which is very thin in profile rather than thick and UFO shaped, and we're talking anywhere, cataract can be anywhere from 3 to 5 millimeters, and the lens implant is 0.9 millimeters in thickness. So really doing that surgery in patients with narrow angle glaucoma early enough can decompress the whole system and be essentially curative for them.